In this video, we'll be looking at some of the ENT causes of dizziness and how to distinguish these conditions by understanding how they actually affect the ear. To begin with, there's a bit of terminology to understand. Dizziness itself is quite a broad term that can be used to describe sensations ranging from lightheadedness to imbalance. And this isn't always caused by a problem with the ear. Things like irregular heart rhythms, low blood pressure, and even thyroid disease could also cause symptoms that fall under the term dizziness. A specific form of dizziness is called vertigo, which is defined as the false perception of movement in space. And there are two forms of vertigo. Objective vertigo, where the patient feels like their environment is moving or spinning around them, or subjective vertigo, where the patient feels like they're moving or spinning in relation to their environment. The causes of vertigo can also be divided into central causes, where the issue is within the brain, or peripheral causes. Central vertigo involves damage to the brainstem or the cerebellum, and these causes include strokes, multiple sclerosis, or brain tumours. This video, on the other hand, will focus on peripheral vertigo, where the pathology is within the inner ear, and specifically the parts of the inner ear that are concerned with balance. Central and peripheral vertigo can be distinguished clinically by performing the HINTS examination, which is explained in more detail in a separate Make a Medic video. We'll now have a closer look at the ear. The balance system, or vestibular apparatus, of the inner ear has several components with normal physiological processes, and there are hair cells lined by cilia which serve as the sensory receptors of this system. Disruption to any of these components will result in vertigo. So first, we have the semicircular canals, which detect rotational movement. These canals contain a fluid called endolymph, and when the head changes position, there will be a change to the motion of this endolymph, which gets detected by our hair cells. Second, we have the utricle and the saccule, which are known as the otolith organs because they contain otoliths, small crystals of calcium carbonate that cover the hair cells. Different orientations of the head will cause the otoliths to pull on the hair cell cilia and induce a signal from these receptor cells, which may be excitatory or inhibitory. The utricle detects linear accelerations and head tilt in the horizontal plane, whereas the saccule interprets movement in the vertical plane. And we also have the cochlea within the inner ear, which is responsible for auditory processing rather than balance. But it is in close proximity to the vestibular apparatus, so it can get affected by some of our balance diseases. And the final part of this peripheral balance-related anatomy is the nervous system within the inner ear. The cochlear nerve transmits the hearing information from the cochlea, and the vestibular nerve transmits the balance information from the vestibular apparatus. These two nerves then converge to form the vestibulocochlear nerve, the 8th cranial nerve, which carries all of this information to the brain. Now let's look at some of the main causes of peripheral vertigo. And you might be familiar with the names of these conditions and the buzzwords associated with them, but we're actually going to look at how these conditions affect the vestibular apparatus, which will then make it easier to remember and appreciate the signs and symptoms that they cause. The first and most common balance disorder is BPPV, which stands for Benign Paroxysmal Positional Vertigo. BPPV is typically caused by the otoliths, the small calcium carbonate crystals, getting dislodged from the utricle and migrating towards one of the semicircular canals. Once they reach the canal, usually the posterior canal, they disrupt the normal movement of endolymph, and this causes vertigo. This explains why BPPV is triggered by movements that stimulate the posterior semicircular canal, such as looking up and down or rolling over in bed. BPPV episodes tend to be brief, usually settling within a minute or so. And the main investigation is the Dix-Hallpike test, which is a maneuver that specifically targets the posterior semicircular canal to assess for its involvement. And a positive test will produce the symptoms of vertigo and nystagmus. And the main treatment for BPPV is the Epley maneuver, which aims to move the displaced otolith back into the utricle so that it stops disrupting the semicircular canals. Meniere's disease is much rarer, and the pathophysiology is not fully known. However, it appears to be caused by a disorder called endolymphatic hydrops, and this is where there's an excessive buildup of endolymph fluid, which then fills the balance and the hearing components of the inner ear. This then interferes with the sensory cells of both the vestibular and the auditory systems, resulting in the classic symptoms of vertigo, hearing loss, and tinnitus. Meniere's episodes tend to be a bit longer than BPPV, lasting from 20 minutes to several hours, and the auditory symptoms of hearing loss and tinnitus can actually become constant over time. Meniere's can be definitively diagnosed based on the clinical symptoms, alongside a hearing test confirming the presence of sensorineural hearing loss. And there is no cure for Meniere's disease, but a range of conservative medical and surgical options can be used to manage the condition. One commonly used medication is called beta-histine, which is thought to reduce the fluid buildup in the inner ear, although the evidence supporting its use is weak. Next, we'll look at vestibular neuritis and labyrinthitis. These two conditions share similarities in that they are both self-limiting inflammatory conditions affecting structures in the inner ear, which leads to vertigo. Unlike BPPV, the symptoms tend to last for a few weeks before resolving, and they're most commonly caused by a viral infection. The key difference between these two conditions is whether or not the patient's hearing is also affected. So in labyrinthitis, the entire labyrinth is inflamed. This refers to the whole maze of fluid-filled channels in the inner ear, which includes the vestibular apparatus as well as the cochlea. The involvement of the cochlea means that hearing can be affected alongside balance. Meanwhile, in vestibular neuritis, the inflammation is limited to the vestibular nerve, which is only concerned with balance. This means that the hearing remains unaffected, and it's just balance that's affected by vestibular neuritis. The final major cause of peripheral vertigo is an acoustic neuroma, otherwise known as a vestibular schwannoma. These are benign tumours that develop on the vestibular cochlear nerve, and they arise from the myelin-producing Schwann cells. And the symptoms tend to develop gradually as the tumour grows, but since it's compressing a nerve which carries balance and hearing information, the symptoms will include vertigo as well as hearing loss in the affected ear. If the tumour grows further and becomes particularly big, it may compress other nearby nerves like the facial nerve and cause further symptoms as well. An MRI scan is the investigation of choice to identify the tumour, and treatment requires removal of the tumour through surgery or radiotherapy. Now that we understand the pathological basis of these conditions associated with vertigo, it's quite easy to distinguish them based on their symptoms. We can classify BPPV and vestibular neuritis as the conditions that exclusively affect balance without affecting hearing, as only the vestibular apparatus is affected. Meanwhile, labyrinthitis, acoustic neuroma, and Meniere's will present with vertigo alongside auditory issues such as hearing loss and tinnitus. We can also distinguish these conditions based on the timing and the pattern of their symptoms. BPPV and Meniere's cause episodic symptoms, although the episodes in BPPV tend to be much shorter. Vestibular neuritis and labyrinthitis will cause continuous symptoms due to the inflammation, but this is self-limiting. Finally, acoustic neuromas will cause continuous and progressive symptoms as the tumour enlarges, and this will only resolve when the tumour is removed. If you combine all of this together, you can create a simple cheat sheet for yourself for the different peripheral causes of vertigo. And if the patient doesn't seem to fit with any of these conditions, then you might need to check their medication history and look for drugs that can be toxic to the inner ear. These include aminoglycoside antibiotics such as gentamicin, NSAIDs, diuretics, and even some chemotherapy agents such as cisplatin.